Well, Treasure, thank you very much for your contribution to our discussion today. I'm Wendy, I'm a GP. This is Treasure, pharmacologist, and we're going to talk about hyperemesis and its measurement. So Treasure, fortunately, hyperemesis is not a common condition, but when it strikes, it can be diabolical. So we can have women who are dizzy, who are tachycardic, who have a significant postural drop, whose urine output is down. From a pharmacology perspective, look, what's the best strategy when we're confronted with a woman like this in our clinics?
Okay, I think we've got to look at nausea and vomiting in pregnancy as a continuum, and the tools in our toolbox are used across that continuum. So if we start off with simple morning sickness, which for the patient themselves is not so simple.
Morning, noon and night sickness.
Morning, noon and night sickness. Mm-hmm. You can divide this broadly into two categories. Women that suffer from nausea and those that have nausea and it goes on to vomiting. And the drugs that we choose for each of these conditions are slightly different. So the woman that tends to be nauseous often does better on a drug that affects dopamine, like Stemetil, prochlorperazine, a phenothiazine, because it's working more on the vestibular apparatus and can prevent them going on to actually starting to throw up. But for the woman that, puts her foot on the floor at 7 o'clock in the morning and has to throw up, you're going to need a broader range of tools. So not only drugs that impact on dopamine, but ones that have prokinetic effect, like metoclopramide, and that work across the neurotransmitters. So drugs that have effect on 5-HT3, serotonin in the gut, as well as in the chemosensitive trigger zone, like metoclopramide, can be quite useful in that regard. Other agents that we often get asked about, if we start at the beginning, vitamin B6 pyridoxine. Now, it turns an IV bag yellow, and you'll often see it used in the emergency department, but really you've got to use very big doses, 25 milligrams 3 times a day. You're pushing up to the sort of doses that, if you need it regularly, gives you risk of peripheral neuropathy. So it's not really an effective option in the low doses that are often in morning sickness dose forms. Other phenothiazine or antihistamine-like drugs, such as doxylamine in the old Debendox, is in the same category as Stemetil, prochlorperazine. If those simple measures aren't working, then you need to think, well, where do I go next? And by that stage, you're starting to see dehydration as an issue. Mm-hmm. So it's about how much fluid can the woman retain. And if she's feeling really quite ill, there's a role for agents like ondansetron that, again, are more selective agents on 5-HT. And the beauty of drugs like ondansetron is that they come in not only tablet form, but they have wafers, and so this can be put on the inside of the mucous membrane, and it's not dependent upon the patient being well enough to swallow and retain a dose.
Also, Stemetil has an option.
And Stemetil, good old-fashioned Stemetil, which is one of my personal favourites, has a suppository. It's quite sedating, so the 25 milligram or dose can be a little bit high, so you can take the torpedo and cut it down the middle lengthways and give 50% of the dose. Mm-hmm. And often that's quite useful for someone going to bed who wakes up in the middle of the night throwing up, and it can allow them to get through the night and sleep, and it gives some residual effects in the morning that can be beneficial. Mm-hmm. So if we move beyond the prescription medicines, the other option that is possible is ginger. And if you'd asked me 10 years ago my feelings about ginger, I would have been a lot more sceptical because we didn't have the evidence base. But as long as the dose form is an effective dose, and many of the commercial ginger preparations are in too low a dose, but if you've got a standardised extract and an effective therapeutic dose, then we've now got meta-analyses saying that it's comparable to the simpler agents like metoclopramide and prochlorperazine, and so it needs to be part of that toolbox.
Do you have an effective dose? What should we be looking for?
Yes, it's in that 150 to 300 milligram of
Per
standardised extract per
day?
dose.
Right.
Per dose.
And Stematol, though, sometimes our pharmacology colleagues will say that's a category C, can't be used.
Yeah, and again, it's about understanding those categories. So category C means it is not causing congenital anomalies, it causes fetal toxicity, which is a second and third trimester effect. And so we can use Stematol quite safely early in the pregnancy, and like drugs for depression, for example, they will accumulate if you need to keep using the drug regularly as the pregnancy progresses to term. But for most women, by the time they've got to about 12, 14 weeks, they're over the hump. Yeah.
You mentioned the bag of fluid with the yellow.
Yes.
Is there a role for IV fluids?
There is a very big role for rehydration and IV fluids. And if we move now beyond the nausea and the vomiting to the hyperemesis, then that is the mainstay of treatment, to which we would add a Ligactyl, chlorpromazine, which is just an IV form of Stematol in a sense. So they're all the same family of phenothiazine, just a little bit more potent, and perhaps an injectable ondansetron or first cousin.
Are we still using the prednisone and such, or hydrocortisone?
Yes, it is used, but not as routinely as perhaps we would have 5 years ago, because we didn't have some of those stronger antiemetics that can ameliorate symptoms a little bit earlier.
So the ondansetrons?
So the ondansetrons, yeah. Okay. So the idea is for someone that has more than one episode, and they get to know that their symptoms are evolving, to get to medical care early so they can be rehydrated, and we don't need to go as far as needing to use the corticosteroids.
Okay, wonderful. Thank you.
Thank you.